All right, I have just let folks in our chat room know to refresh their pages. Hello, everyone. My name is Emily, and I am the community manager here on 2 Diabetes, working with Diabetes Hands Foundation. And we are here today with an interview on an incredibly important topic, and that is post-operative glycemic control in people with diabetes. So this is a very impressive sounding term. What it means is if you have diabetes, and you need to have an operation and you're going to be an inpatient in the hospital, how do you make sure that your blood sugar is controlled to the best possibility in that situation? And we have with us a couple of folks who conducted a study in trying to improve post-glycemic control post-operatively. And today they are Dr. David Mosen and pharmacist Betty Young. We were going to be joined today also by Dr. Karen Mularski. She was not able to join us, unfortunately. So David, let's start with you. You're one of the authors of this study that we're here to talk about today. And, oh, look at that. David just fell off of the call and just rejoined. Betty, let's move over to you while David seems to be having some technical glitches. Betty, can you tell us who you are and what was your involvement in this study that we're going to talk about?
Okay, so I wasn't doing the research work, but I was doing the work in the hospital when patients came in and had a surgery. So I'm a group of pharmacists, or there's a glycemic team that manages patients that have high blood sugars, they're diabetic, or maybe they aren't diabetic and they have a post-surgical high blood sugars. So these patients may be on insulin, and so the team manages the insulin for these patients. They may be on an insulin drip, and then we transition them off the insulin drip, and then give them subcutaneous insulin doses and manage that, make the adjustments, and follow if their diet changes. We may make some further adjustments, and really it's just making sure that their blood sugars are well controlled, because it's so important for patients. Kind of in a nutshell.
Cool. We're going to talk more about that, but it looks like Dr. Mosen has been able to join us again. So, Dr. Mosen, the camera is on you. Can you please introduce yourself, tell us a bit about you, and then talk about this study and what it was and why it's important?
Sure. So my name is David Mosen. I'm an evaluator with the Center for Health Research here in Portland, Oregon, and my role was to lead the evaluation of the study with Dr. Karen Mularski and other folks in Kaiser. And basically, we sort of designed the study and ran all the analysis and came up with the results. And so this was really the first study that looked at an inpatient pharmacy program to manage glycemic control, and we found the program was effective to increase better glycemic control and reduce post-discharge utilization. So it was great, and I'm excited that we could come and talk about it a little bit.
Before we go any further, I would love for you to define post-discharge utilization in the context of this study.
Sure. So what we did is we have an electronic health record here within our organization, and so what we mean is after a patient leaves the hospital, whether they come back for either a hospital admission or an emergency department admission, or visit. So that's one of the things we want to avoid. And so we measured that within the 3 months after the patients were initially discharged. And so those are the things we were looking for, is to see whether they came back kind of of effectiveness. Yeah.
So what typically is done around post-operative glycemic control before this study, before trying out this different protocol to try and improve these? What generally is usually done for people with diabetes who have an operation?
Sure, and I'll let Betty jump in. I'll just kind of give my non-clinical hat on this, and our other author Karen is a hospitalist, and she can. It's not here, but she can elaborate. But basically, it's before it wasn't coordinated. So we had specialists, kind of surgeons that were trained to be surgeons, but they weren't trained to manage glycemic control. And so it existed in an environment where they were kind of performing that role, and this new role more was the pharmacist kind of took a lead role to do that, and so they were coordinating all different aspects of helping to write orders and helping to educate about sort of where the patient was in terms of glycemic control and things like that. And so Betty, do you have thoughts on kind of before and after, sort of what the differences were? That's kind of my high level. Was kind of coordinated, not coordinated before, and very well coordinated after.
Yeah. So actually, before the surgeons, they're not as following, I guess, the patients as closely in terms of looking at knowledge about what to do with managing the blood sugars. And so, they may order some insulin orders, but may not be as focused on that. They're focused on the surgery part for the patient. And so when the pharmacist came in, we really focused on the patient. These patients we follow, throughout our whole shift or the whole day that we're on, and then keep on following them, and they're making fine-tuning adjustments to their blood sugar control while they're in the hospital. So we're very more, I guess, comprehensive in looking at that.
So I have a question about that. So the pharmacist post-operative, and I guess pre-op and during op and all of that, is actually dosing insulin for patients who have diabetes and are in for some kind of surgery?
So generally we follow the patients post-surgery. That's when we usually get consulted. And so a patient may come in, but before they come in, they usually have a pre-surgery visit, and they'll be instructed to, if they're taking some diabetic medications, they may be told, your surgery's tomorrow morning, so go ahead and don't take your short-acting one in the morning, but you can take your long-acting one maybe at night. And they get instructions on what to do, on whether to take the oral medications or the insulin, short-acting, long-acting, or intermediate. So they get that information before, but when they come in, they go to surgery, their blood sugars are not controlled during surgery. They may be placed on insulin infusion. And then after surgery, they'll complete their surgery, and then we'll be consulted, and then we further manage their blood sugars with the use of insulin and make some adjustments. If they're on an infusion, we will take them off the infusion at the appropriate time. Depending on the procedure, they may need better control. We'll, per the protocol, follow that and make adjustments and change them from an infusion to subcutaneous as necessary.
So you talk about, that preoperatively a lot of folks are told that to be sure to take your long-acting insulin, but do not do your short-acting bolus in the morning. And
so they might not take the night before, they usually would take their long-acting insulin or intermediate insulin like NPH or Largy. But in the morning, if it's a morning procedure, they usually are not to be eating anything, so they won't take any short-acting or their oral diabetic medication.
Right. How about people who are on insulin pumps? So they're only on short-acting insulin, and of course, if they take off their insulin pump, then blood sugar is going to rise it will start rising pretty quickly. What has been typically the protocol for that for people on pumps?
Well, currently at our hospital, we don't have insulin pumps being used. However, I believe that's discussed with the patient how we would likely have the patient on an insulin drip for a time being, and then transition to use subcutaneous insulin after they're off the insulin infusion when they're stabilized. But we are working on getting an insulin pump infusion protocol in place. And And I think we're going to start small, a small population in the future. It's not set up yet.
So then for this particular study, it was recognized that we wanted to improve post-operative control of blood sugar. And first off, what went into making that decision? What was the determination that this is something that needed to be improved? And I think this is a question for Dr. Mosen here.
Yes. So I think where we were before was we didn't have the levels of glycemic control were not as high as they could have been, and so we saw a pretty big improvement afterwards. And so I think there's the sort of you don't want them too tightly managed, but you want them managed well enough. And I know, and Betty, you may have thoughts on this too, but there was a lot of the work that went into developing the protocol in the hospital, and it was a very iterative process, and they kind of landed on the two things are good glycemic control to improve that, and then to reduce the time that people had that didn't have hypoglycemia. So basically reducing the time they have hypoglycemia and improving the time they have good glycemic control. So both those things. But did you have any thoughts on how were you there when the protocol was actually developed? Because I know there was a lot of effort that went into getting the protocol where we wanted it and that type of thing.
So actually, I wasn't in the group that actually developed the protocol, but I was there when we started using the protocol. So I was one of the first pharmacists that started, I guess, implementing it and working with patients. But I know it really involved a lot of people, the endocrinologists, the surgeon, the lead physicians for this, and then, of course, the pharmacy department as well in implementing it. But hopefully that answers what you wanted to know. Thank you.
So we have some questions in the chat room, and I think this is a question for a lot of people with diabetes, particularly who use insulin pumps. What is the reasoning behind not allowing people to stay on their pump when they're in the hospital? Because for those of us who are used to managing our own blood sugar using a pump, it feels like, well, nobody really knows how to manage my blood sugar except for me, and this is the tool that I use to do it. So why not allow me to do it while I'm an inpatient, even while I'm in surgery? Do either of you know what is the reasoning behind that?
Well, I don't know all that reasoning, but one of them is, when the patient's in surgery, I know the patient has the best knowledge about how to manage their pump, but when they're in surgery, they're not able to do that, and so that's a great concern. What if something goes wrong with the pump while they're in surgery, or they're out of surgery and they're not stabilized yet? We want the patient to have good control, but we don't want them to get hypoglycemic. Of course, we don't want them to get hypoglycemic, but we do want them to manage. If we can't.
Betty, could you speak up a little bit? We're starting to lose your sound.
So, the patient knows their pump the best, but when they're not able to manage their pump, when they're in surgery or they're still recovering, they're not able to do that, and so that's a great concern. It's a safety issue. So that's one of the reasons, I think.
All right. So we have not yet actually dived into what was this protocol that you were testing in this study. David, can you tell us what exactly were you testing? What were you looking at that was different than what Betty had described that had been sort of usual treatment previously when somebody with diabetes came in for a surgery? What was the thing you were comparing that with?
Right. So we were comparing before. So we had a cohort of patients before we did the surgery, and that was sort of the non-coordinated, where the pharmacist wasn't really involved with the study or with management of patients. And then after we rolled this out for about 6 months. And then after, we had the pharmacist playing sort of a key role, and they contacted the patient when they were in the PACU, the post anesthesia unit, and And then from that point, the pharmacist was involved in all of the sort of management of the patient until they were discharged. And so we basically were comparing sort of the before state to the after state. And we had glycemic control measures and utilization afterwards, and cost. And so basically we found improved glycemic control, but then a reduction in readmissions, and then a reduction in costs afterwards.
And was there a particular population that you were studying this in? Was it people?
Sure, yeah. So it was actually general surgery patients. Yeah, so it was all different types. There was general. There was all the different groups, thoracic. So it was basically a kind of a snapshot of our surgery population at Sunnyside. So it was the entire group. And did you find, Betty? Did you see any more groups that you when we looked at the data, it was primarily, I think, about a third general surgery? Or were there more groups
surgical patients, a lot of ortho patients,
right.
knees, those kind of things. And there's some thoracic patients as well.
So really good mix of basically we had a good snapshot of the population at Sunnyside.
And were these all people who have diabetes, or were you looking at glycemic control actually in people who do not have diabetes as well? Because I know that can actually be an issue in people who don't have diabetes.
Sure. Good question. So we actually took all comers. So it was patients with and without diabetes, and so there were patients that could develop stress hyperglycemia, and that's one of the concerns is a patient comes in and they don't have a blood sugar issue, but the stress of the surgery can elevate their blood sugar. So basically, we took an entire snapshot, and to get in, they had to just have they had to have 2 or more point of care tests, blood sugar tests. And so the idea was, with this, you mentioned what was different with the new protocol. The new protocol actually, there was more of an emphasis to test blood sugar to determine whether somebody was elevated or not. And then if they were, then they would continue to monitor them. If they were not, then the patient wouldn't have any more contact with the pharmacist. But that was sort of the difference. It was kind of a population approach to managing blood sugar control. So I can't remember specifically, but I think about 23% of the population was diabetic. So it wasn't the whole group. But there was the other group you would kind of deduce would be stress hyperglycemia that we were looking at.
Wow, that's a lot more stress-induced hyperglycemia than I realized existed among people who don't have diabetes. That's really pretty amazing. So right. Is managing blood sugar, blood glucose post-operatively different in people who have stress-induced hyperglycemia versus actual diabetes?
That'd probably be a good one for Betty. I think because that's kind of above my kind of clinical knowledge. But I think how Karen probably would answer that in the hospital, it might act the same. So when someone has stress hyperglycemia in the hospital, that might look very similar, but once it's brought under control, it may look different after they leave the hospital. So I don't know, Betty, what are your thoughts on that in terms of are they different after they leave?
And the stress, I think they're very similar. I mean, even if you have you're diabetic and non-diabetic, there can be that stress, and you may need more insulin. The non-diabetics still would need some insulin to help control their blood sugars, and if they're diabetic as well. The one thing that may be more of a difference is if they've received some steroids. That can really make a difference in managing some of these patients, whether they're diabetic or non-diabetic.
Yeah, I think a lot of us, those of us who have diabetes, who have taken steroids before, know that that's a doozy on your blood glucose control. So I have needed my pharmacist myself for that.
But I think to your point about the populations, I think before we started this, there was more of an emphasis, I think, more on probably the diabetics and those that had diabetes risk factors. I think after the program was implemented, it was capturing a more wide net, to look at anybody that potentially could have an issue with their blood sugar during their surgery. Yeah, so it was more of a kind of a wider lens we were looking at. Yeah.
So in the chat room, Marty asked a great question, which is when you talk about glycemic control post-operatively, are there specific goals that you had in mind that you were looking at in terms of glycemic control?
Well, we like the blood sugars to be less than 150 in general. I mean, if they're eating, we have our protocol addresses that we like to have them less than 150, randomly less than 180. If they're on an insulin drip, generally it's 110 to 140 for the blood sugar. So the protocol kind of drives what our goals is for the blood sugars that we reach or trying to meet.
Mm-hmm. And then did this protocol include what to do in case of what we might call blood glucose excursions while in the hospital, while under the care of a pharmacist? So if somebody who was being studied in this ended up with either a really high blood sugar or really low blood sugar, was there a protocol with then what to do for that?
Yeah, the protocol does have steps to take care of. If the blood sugar goes down low, less than 70, we have to check their blood sugars, and give them some dextrose for the protocol. It guides them as to how much, and then we check their blood sugars again, 15 minutes, and keep on doing that. That's when they're off an insulin drip. Of course, when they're on the insulin drip, there's a protocol that there's a nomogram or calculator that guides the nurse to how to adjust the insulin drip, insulin infusion, and the steps to take with that as well. And it may include giving dextrose if it goes down below a certain point. They'll do that.
Right. Here's another one from our chat room, and that is, does the range of sort of acceptable blood glucose, is it different post-op than someone might normally have the rest of the time? So do you count for, are you aiming for basically a higher range than you would normally advise people to aim for?
Is this while they're in the hospital or at the expectation level after the discharge?
While they're in the hospital.
They're pretty much the same range. I mean, we do like it to be definitely less than 180, but I mean, pre-meal, when they're off the drip, like to be less than 150. I mean, it's probably, it could be tighter controlled than some of them have it at home. Because I know in talking, we do interview the patients and talk to them and ask them what they've been taking before, and some of them say, the clinician may say, well, you're okay with this range, but it's their clinician-patient relationship that kind of guides what their goals are as an outpatient.
Right. You had mentioned earlier, Betty, that a lot of times people with diabetes who are on diabetes medications are advised to cease medication preoperatively for some very good reasons, like you're not eating. How about metformin? How about folks who are on oral agents for diabetes? Are they advised to stop taking those before an operation, or do they continue?
And usually the morning before or the morning of, they wouldn't take any of the oral medication. So we have that in place. Well, and then while they're in the hospital, for our protocol, they're not on any oral medications. We just use the insulin to manage their diabetes or to manage their blood sugars for the most part.
And another question in the chat room that you just led me beautifully right into. What kind of insulin do you use when you have somebody set up on an insulin drip? What is it?
We use regular insulin.
So for David, Dr. Mosen, can you talk, now that you have conducted this study, and it seems like it had some really great outcomes and indicated that this protocol is more effective for blood glucose management post-op than what we had been doing before. What happens next with that information?
That's a good question. I think what our next steps are to continue kind of monitoring the program, which I think that's happening now, and then Karen or Mularski, our other co-author here, we talked about potentially sharing this with the other Kaiser regions, and so I think that's probably another step is how can we sort of share this, because I know it's not used everywhere. So that's probably a next step is how can we sort of disseminate and further evaluate. Yeah.
Is there any, so you folks work at Kaiser, is there any system within Kaiser to, once something like this shows to be effective through study, to try to actually proliferate it throughout the Kaiser system and make it the protocol that is used? Yeah,
when we kind of operate like, we have 8 different regions, we're kind of 8 different systems, but but in the research community there is this sort of ability to share, and I think, and Karen's better in tune with this than I am, but I think there is groups that where where the next step would be to kind of take this and adopt it in other places and figure out kind of how can we move certain patients with real poor glycemic control, how can we sort of improve them, and does it work with all types of surgery and that kind of thing. So yeah, so I think the next step is to sort of adopt this in other places as well. Right, that's a good. One thought is we have another hospital. We have our East Side Hospital, West Side Hospital, and one thought is to kind of bring this over to the West Side Hospital as the next step. So that's probably kind of where we're going next, and then trying to share it with other KP regions as well.
So you're in Portland, right?
We're in Portland, yeah. So we serve kind of the Portland area, kind of Southwest Washington, that piece.
We have a member in the chat room right now who is in Portland. So David in Portland, if you need a surgery, now you know where one place that you might want to go to have that done. And I had a follow-up question actually for Betty, getting back to the insulin that is used. As you can imagine, I'm sure both of you, getting any kind of general anesthesia is so terrifying, or can be so terrifying for people with diabetes, because we're used to feeling like the only thing that sort of keeps me alive is me, keeping track of my blood sugar and dosing my insulin. And if I'm knocked out, how can I possibly be safe, right? So this is, I think a lot of us can get really like, oh, this can't possibly work. And one of the questions in the chat room that came out of the question about what kind of insulin is used in the hospital if somebody is on a drip is, what if you don't respond well to that particular insulin? Because different insulins can work differently for different people, and not everyone tolerates the same kinds of insulin. Is there ever an option to use a different kind of insulin, say, if you said that you use regular, to use some other fast-acting insulin for folks who don't respond well to regular?
Okay, well, for a standard insulin infusion, we do use regular insulin. However, you're right, people do have allergies or sensitivities, and sometimes they can't use that as the short-acting insulin. I haven't actually had experience where we've had a different short-acting insulin used for infusion. However, I know that we do use Lispro as another short-acting insulin when we do subcutaneous insulin. And I know there's different brands of regular insulin too as well, and so we may use another brand, so to speak, if they're sensitive to one over the other. And if they're sensitive to or cannot use Lispro, we may get Aspart or another short-acting insulin. So we do look at the patient as well.
Mm-hmm. And how about, what kinds of training do pharmacists get to do this sort of thing? Generally, people with diabetes feel like, well, an endocrinologist, like my endo, my endo doesn't actually know how much insulin I need to cover a burrito, right? I know how much, but my endocrinologist doesn't actually know that sort of thing. But maybe if I were under general anesthesia, my endo might be sort of the next person I would want in line to figure out how much insulin I needed. And then maybe my certified diabetes educator. I think people aren't aware of what kind of training people in pharmacology and pharmacists actually get to learn how to manage blood sugar. Can you talk a little bit about that?
Well, we have done, let's see, how do I say? When the program started, especially, we did have an endocrinologist that we were closely worked with that we would meet weekly and could also consult them via phone or whatnot. And we'd bring up cases and review those cases, those patients' situations, and try to get a better understanding of how to manage patients and what could we do better or change in managing a patient. So we did get a lot of consulting with the endocrinologists. We were closely worked with them. We did, have some didactic training as well. And that's a lot of how we started. And then we still consult with doctors like Dr. Mularski about patients, and especially if they're hard to manage. We do have the diabetic educators that we can also consult with, and they help also manage patients too, and seeing if there's some other things to do. So there's a lot of resources. We have in the hospital. We have a glycemic control work team that talks about managing of the patients as well.
That is wonderfully reassuring. So we have another question in the chat room. This is a really interesting one, and I think this one is for David. So that it seems like this protocol has been really, really thoughtful around planned surgery. Has any thought been given to how this protocol might work for unplanned surgeries, like emergency room visits that result in an emergency surgery?
Yeah, that's a question, and I think to clarify how people got in is they had they came in, they had a glycemic test to measure their blood sugar, and so this I probably would defer to Karen and Betty. I think I would imagine if that if the patient had issues with blood sugar control, even for an emergency surgery, we'd want to know, unless there was some reason to not do it, from a tolerance standpoint. But I think of the same, because the point of intervention was it was in the PACU, so I think that would still work. But I don't know, Betty, do you have thoughts on that? Did you see any urgent surgeries for the patients you worked on?
Sometimes we do get patients before they go to surgery, like if they are in the emergency room and then they're going to go to surgery, or so we may help with those patients. I mean, we do curbside consulting. We might look at some patients and see some blood sugars that are really high in a patient, and try to help in the management of those patients to make suggestions and maybe making adjustments. So it's not, our focus is really on surgical patients, but it's not to say that we don't help to manage other patients if we're called upon, or that we see something that maybe we feel should have better control. We may give some recommendations. So it's not just surgery patients that we also follow. That we help with. But per the protocol, it's for surgery patients.
And those were primarily planned surgeries, not like an urgent, like someone who came in unexpectedly. Were there those cases?
Usually, if the blood sugars are really high, I think in the emergency room they would say, "Oh, I think we need to start the patient on insulin just to get them to manage as well."
Because the process, I think, would be the same. You would follow a similar protocol for those patients. Yeah.
So in terms of the relationship between the patient and the pharmacist post-operatively, you said that even after patients are discharged, do they still get follow-up from the pharmacist who was helping to manage their blood glucose while they were still in the hospital?
It It will vary, especially if it's a patient that needs adjustment, say on their insulin, or they're a new start that they required some insulin management. The doses were quite different than what they were on prior to coming in or during the surgery or during hospitalization, and then the doses were quite different. We may have a what we call diabetic case manager become involved with them. So we would go and pass their name on, and they would contact the patient and help them if they need some insulin adjustment. We also like to, if the patient has a high hemoglobin A1C, 8 and above especially, we get the diabetic educator involved, and they may have also have some recommendations as well. So there's post-surgery, post-discharge, there is some a program in place that a patient may fit into where we would follow that. And we can also message to the primary care doctor, maybe that we've made some changes or make some recommendations. We do talk to the patient. Maybe their hemoglobin A1C, they're just being diagnosed because we watch their, measure their hemoglobin A1C and follow their blood sugars, and we may talk to them about some other things other than diabetic medications, but lifestyle changes and diet change, exercise, weight loss, and things like that. We may talk to them too as well, and then have them follow up further with the primary care doctor.
So that's actually really comprehensive blood sugar management. It's not. It seems almost like in this protocol, it's not just like, let's get you out of the hospital safely and through that sort of initial getting back home and starting to heal process, but that if somebody has, for example, a really high A1C, that you'll actually continue to work with that person to try to lower it. Would that be the case even if they had had that high A1C before their surgery?
Well, we are able to, I feel fortunate this way, with this program, we are able to identify some people that are diabetic and they didn't know it, so then we are able to help further get them into management of their diabetes.
And there's another thought too, is we actually have a pretty integrated diabetes care management program within our own program. So if someone had high A1C, they'd have other resources with our own Kaiser system to get resources.
So did you basically find that in studying this protocol, you also identified a lot of patients who just needed more help and more guidance in managing their diabetes, and you could kind of shoot them in the direction of getting those needs met in addition to doing their surgery? I think that one's for Dr. Mosen.
Yeah, right. I was gonna say probably Betty, but I think my gut reaction would be we probably didn't identify new diabetics. Would be my gut reaction that these are patients that are diabetic in our program are pretty well managed and engaged. But that'd be a good question though, Betty. Did you see any sort of new diabetes that wasn't previously recognized when you were interacting with patients? I would think the answer would be no, but I could be wrong on that.
I'll have to say yes, we have. I mean, I don't know the numbers. Of course, they're not as many, but I did have seen people that were not ever aware that they were diabetic. And I've had some that high hemoglobin A1C is 9.5, and they've never been on anything. And they're only less than 30 years old. So there are some that are out there that just they think they're young and they're healthy, but they aren't aware of this. And then they come into the hospital and they get all these testing because they had a surgery, and then we find out that they need better blood sugar control. So we do identify some.
That's pretty incredible, and we don't think of that as ever a way that people identify that they have diabetes. As I went in for surgery and found this other thing that I didn't know was a problem. You actually have a comment in the chat room that it's fantastic that this is another way that diabetes can be identified in somebody who maybe otherwise wouldn't catch it for a long time, or otherwise wouldn't catch it until potentially they had started to develop complications even.
Yeah. So I was going to say that they may not be pre-planned surgeries that maybe those types of patients arise versus pre-planned surgery.
All right, it looks like we have sort of partly lost Dr. Mosen. I see an icon that represents David, only it says Mary on it because he's joining from somebody else's account. But we have also run out of questions in the chat room, so it's a fine time to wrap up as long as we have lost one of our guests and run out of questions. Betty, thank you so much for being here with us today and for the wonderful work that you do for caring about people who have diabetes and caring about glycemic management. And David, if you can hear me, thank you very much as well for your good work. Camera's on you for a moment, Betty, in case you want to wave goodbye to our audience.
Okay, well, yeah, I really appreciate you inviting me to participate in this, and I'm hopefully we can help patients have better control and management. Thank you for your time.
Absolutely.
Okay.
Thank you. Bye-bye, everyone. Thanks for being here.